Greetings, wherever you're joining us from around the world. I'm delighted to welcome you to our Australian Centre for Health Law Research Coffee with a Colleague online series. This series will include various conversations between our researchers and a collaborator or a colleague about their mutual research interests or projects that they've been working on. Before I begin, in keeping with the spirit of reconciliation, I acknowledge the traditional owners of the lands where QUT now stands. I pay my respect to their elders past, present and emerging, and acknowledge the important role Aboriginal and Torres Strait Islander people continue to play within the QUT community. Before we start this conversation, I'd like to make some brief comments about the Australian Centre for Health Law Research. Our research group is comprised of some 28 academics, a large and growing cohort of PhD students and esteemed adjunct professors. We're supported by an outstanding group of research assistants who work on various projects with us. It's exciting to have this sort of critical mass, all these people working together on challenging and important health law issues. The Centre's research spans the health law field from the beginning to the end of life with 4 programs. End of life, planning for healthy ageing, health, society and regulation, and technology, innovation and health. Our researchers are leading debates and investigating the laws, policy and practice in these areas. We would welcome the opportunity to discuss the research we're doing in the Centre and the possibility of collaborating on projects with you. An important goal of the researchers in our Centre is to undertake research that has an impact, that makes a difference. We do this in a variety of ways. Of course, we undertake traditional research and publish those findings in scholarly journals, but we strive to do much more than that by translating the results of our research into improving the quality, safety and accessibility of healthcare in Australia and internationally. Research alone is not enough to make this happen. We need to take our research out into public and policy debates, and these online conversations form an important part of this goal. It's now my absolute pleasure to invite you to join me for coffee with a colleague.
Hi everyone, I'm Eliana Close with the Australian Centre for Health Law Research, and today on ACHLR's Coffee with a Colleague, I'm very pleased to welcome Dr. James Downar, who's Associate Professor of Medicine and Head of the Division of Palliative Care at the University of Ottawa. He's a physician who specializes in intensive care and palliative care, and he also has a Master's of Bioethics from the University of Toronto. For today's coffee, I'm going to talk to James about our area of research, which is non-beneficial treatment at the end of life, sometimes known as futile treatment. And I hope to also ask him a bit about his experiences, both as a palliative care physician and in the ICU in the midst of the COVID-19 pandemic. First, just before we start, I'll give a bit of context about how we work together. James and I have collaborated on publication. We've also worked separately on similar research problems, and he's also worked with other members of ACHLR on a few other issues around medical assistance in dying. And these collaborations arose out of the International Conference for End-of-Life Law, Ethics, Policy and Practice, which Lindy Wilmot and Ben White at ACHLR founded in 2014. It's since had other iterations around the world, with one to follow next year in Salt Lake. So it's great to see the collaborations that have come out of this conference, and I know that ours is not the only one. Hopefully initiatives like this one that we're doing at ACHLR are ways to keep those connections even though we've got travel bans in place. That's enough from me. James, welcome. How's it been going, and do you find your days in this COVID pandemic have changed much? We're really fortunate here in Australia that things have opened up a little bit, but I know that Canada is in a bit of a different situation.
Yeah, I mean, it felt like suddenly everything got shut down here, and that was pretty disruptive for a lot of us because it happened right before our March break, which is a traditional holiday time for us here. And then, of course, all of us then had our usual springtime travel and sunny destination vacations canceled. Schools got canceled, and then sporting events got canceled. And before you knew it, we all had to rapidly adjust to a dramatic new way of living. And we haven't yet come out of it to any significant degree. We're still waiting for our numbers to come down sufficiently to make that realistic and safe. So hopefully we'll be able to catch up to Australia soon.
Let's talk a bit about non-beneficial treatment, which I know you've devoted a lot of your research time to. Can you speak about it generally in end-of-life care? What does it mean, and why, from a physician's perspective, do you try to avoid it?
Yeah, I mean, it's a good question. So again, life-sustaining measures in CPR have been around for a little over 5 decades now. We've developed a number of technologies and treatments that can replace the function of an organ system that isn't working well: the heart, the lungs, the kidneys. And these technologies and treatments have gotten good enough that really we can keep people alive even when they're extremely ill, and even if some of their illnesses might not be curable. Which then obviously leads us to very difficult situations where the only thing keeping them alive is the machine, and there's no prospect that they're ever going to be able to get off the machine. You have to start to talk and have those difficult discussions about stopping it, and then thinking back from that, if you find yourself approaching a similar situation, perhaps not starting it. So even in the early days of life support and CPR, people were already starting to talk and write articles about the challenges that arise when deciding when to use these technologies, when not to use them, and when to stop them. There's clearly a recognition even from early days that there are situations where life support and CPR are just not appropriate. So there are many different definitions that people use for non-beneficial treatment. None of them are universally accepted, but as in a general sense, they all fall into one of a few categories. There's the idea of things that are not effective. So physiologic futility, for example, if somebody has been decapitated or has bled out completely, it is not effective to try to resuscitate that person. So you can't even achieve the proximate goal of sustaining vital signs. There are much more commonly things like quantitative futility or qualitative futility. So quantitative futility would be where you say, well, this person's percentage chance of recovering is very low, below 1%, below 0.1%, some number. And on that basis, they're deciding that it would be futile. Qualitative futility would be to say, well, we think the machines will work and this person will stay alive, but they'll never recover to the point that they'll be independent or achieve their baseline. And on that basis, they're going to say it's futile. Very often, the futility debate and discussion also centers on cost and resource utilization. So conflating the term not cost effective with not effective. And really, that's not correct, but it's important to acknowledge that those are concerns. That the cost, if you think the cost per case would be prohibitive, then that might be a situation where you might not want to do it, but that's not the same thing as saying that it's not beneficial. And then, of course, there are situations where you think it will work. There is a significant chance that it will work, but the far greater chance and almost certainty of very severe suffering or significant burdens associated with the therapy that would make you think it's not worth trying, and in other words, not appropriate. Bottom line is that whatever definition you're using, if you consider something to be non-beneficial, we consider it effectively to be a harm in critical care. And in medicine, we are supposed to do things, we're trying to avoid harm and do good. And of course, when somebody's asking for something, but you think it's harmful, then that gets into a situation of tension that we get into from time to time in medicine, that tension between autonomy and beneficence. When should I respect the decision from somebody, and when do I try to improve a decision through suggestion or strong suggestion? And that happens for all sorts of decisions in medicine.
And can you talk a little bit more about those conflicts? What factors tend to precipitate them, and what avenues are helpful in resolving those conflicts? My angle on this kind of stuff is that decisions about non-beneficial treatment can be very value-laden. So that push-pull is really difficult to navigate, and it's a legal and regulatory question as well as a medical one.
Well, absolutely. It is definitely not a purely medical question. There's no question in my mind about that. And you're right. It is often framed as a question of values. And then, of course, in some cases like this sort of irreconcilable clash of cultural values, the idea of vitalism, that life is of value in any form, no matter what the quality or the degree of suffering to sustain it, versus a more utilitarian approach, that life is viewed potentially as not an absolutely infinitely valuable thing, something of great value, but there are situations where burdens associated with life would mean that we should not be prolonging it with life-sustaining measures. Personally, my feeling is that it isn't really usually about that irreconcilable clash of cultural values, that people from all over the world will have values at both ends of that spectrum. Ultimately, and you have to recognize that every country in the world, there really isn't any country where where everybody receives critical care or CPR prior to death. Even in the United States, where the numbers are probably higher than anywhere else, only a minority of people actually get life-sustaining measures before they die. They go to an ICU before they die, or they get CPR before they die. The vast majority don't get it. So to say that there's this cultural demand that you must provide these things, I think is inconsistent with that experience. But I think it is a lot to do with communication, trust, emotion, and guilt, and a lot about interactions that people have had with healthcare systems, about trust in medical authorities and that sort of thing. And that's where I think really the challenge lies. So that's where you often see people who are immigrants to society, people who are vulnerable, people who have a history of potentially being marginalized within a system, might not necessarily trust what they're being told. And if you don't trust the person who's talking to you, you're not very likely to take their recommendations. And that's where it sometimes can be viewed as a cultural clash, or a values clash. But in my experience, it often isn't a cultural clash in that same way, right? I think that the challenge that we get into, right, is that there's the common perception that shared decision-making is this gold standard, that autonomy is something we must achieve. But in reality, we almost never achieve shared decision-making. There are very often that people fail to understand their illness. There's a real difficulty sometimes in gaining a shared understanding of what treatment options are, what are the actual risks and benefits to a given treatment. Most people, when they have a deterioration, they view it as a temporary setback, not an irreversible progression of their disease. And then, of course, there's the fact that when you get into a critical care unit, mostly these decisions are made by surrogate decision makers, not the patient themselves. And there's often a very poor correlation between what the surrogate says the patient would want and what the patient would actually want.
I think those are some really good points, and two issues that you highlight there. One is the cultural issue and these seeds of distrust that are sown. It seems to me that we really need to do more at earlier stages to prevent that kind of marginalization, or to build those relationships of trust earlier on to combat some of these issues. Do you think that's fair?
Oh, absolutely. There's no question that that's what it's about. I think if you look at the variability in end-of-life practices within different groups within a society, you will see quite a lot of variability. But what is often very clear is you see the same or greater variability among patients cared for by different physicians. So clearly there's a lot to be said for the approach being made to the patient, how things are being explained. I used to joke, there was one time where one of the oncologists at the hospital where I used to work, who was a well-known pain expert and palliative care expert, and he had a huge practice in lymphoma and breast cancer. And one day, one of his patients ended up in the ICU with necrotizing fasciitis, not an end-of-life scenario, got better. And he was going to come and see her, and I called him up, and I was joking with him and said, do you need directions to the ICU? Because that's literally the first time I'd ever seen one of his patients in the ICU, because he had prepared his patients who were coming at or near the end of life for these decisions. And they were able to make a transition towards palliation. They understood that the limitations of medical care in that context, and everybody was able to sort of be on the same page about what they thought the most appropriate pathway of care was.
And that's obviously an ideal situation, but I think something that we've observed in some of our research around futile treatment at the end of life is that sometimes it's, as you say, different medical professionals who are giving some sense of promise and giving that sense of, well, we can do something, so we will. And that leads to some of the tension, because of course it's hard for people to accept that something is a terminal event when they've been told all along, well, there's always something that we can do.
One of the things you see very commonly now trending around the world is that we are starting to see in many countries an increased use of critical care as people approach the end of life. What you're also seeing is in the final 6 months of life, more people are being seen by more specialists in those final 6 months of life. There are far more handoffs, handovers, people being cared for by multiple different physicians. And to your point, I think if even one of those physicians gives the impression that there's something fixable, that somebody will get a good response to a treatment, you can certainly understand why a patient or a family might be surprised or shocked or upset when other physicians will say, no, it's not going to work. They're still remembering that other person who told them that things were going well. And so, yeah, you're right. I think one of the other problems we get into sometimes, and I use cancer often as the example, but many physicians were taught that as somebody is transitioning and deteriorating, that you don't abandon them. You have to maintain the contact and don't don't sort of cease your interactions with them. And sometimes I think when physicians try to convey support and non-abandonment to people, it comes across as, I'll see you in 6 weeks, I'll see you in 6 weeks. Well, we'll follow up the next time we see each other. Call me, let me know how you're doing. And that gives the message to families that actually this person's going to be fine in 6 weeks or 3 months, and certainly well enough to come in, and maybe there will be treatment options at that time. Again, it's an unintentional message being sent by physicians who are really trying to do their best.
Can you talk a little bit about how discussions about non-beneficial treatment, or whether or not to withhold or withdraw life-sustaining measures, have changed within the COVID pandemic? We've heard a lot about resource allocation, ICU, ventilator allocation, but I haven't heard a lot about what's going on with some of these discussions about how to frame them with families and how people are thinking about them. Do you think that things have changed at all?
Yeah, I think they have. I mean, my own experience has been that, we had a couple of narratives that were coming out of the early days of the pandemic. One of these narratives was this idea that there were too many sick people and not enough ventilators, that you were going to have to start to do this resource allocation or triaging process to allocate your resources to those who are most likely to survive. And of course, some people who were maybe older or had comorbidities, were not being offered ventilators. I think that scared a lot of people. And then the other narrative that came out was the idea that a lot of people were getting this horrible illness. And although most people were not getting sick enough to need ICU, those who did get sick enough to need the ICU basically never came out of the ICU. And we weren't clear on why only a small portion needed it. But if you needed it, you probably weren't coming out of it. And that, 80% mortality rates being published from Wuhan, I mean, that was really scary for a lot of people. And I think that prompted a lot of people to kind of maybe have very frank conversations with their families, to know that this was coming. And if it came, they didn't want to go into an ICU knowing they would never come out and knowing they wouldn't be able to see family members. They wanted to be kept comfortable. They wanted to be around family members. So a remarkable number of people came in during the early days of the pandemic, certainly here in Ottawa, having had fairly recent conversations with loved ones about values, and actually in many cases, I would say a much more pessimistic but ultimately realistic expectation or understanding of the limitations of critical care. So I would say that's in some ways a positive aspect of the information that came out, is that people were talking about their end-of-life preferences and wishes. I think the triage issue on the other end does scare a lot of people. And if you're somebody, for example, from a disability community or a vulnerable population, and you're concerned that you're going to come into hospital and somebody is going to, based on implicit biases or other mechanisms at play, exclude you from getting critical care that might benefit you, even when your chances of survival may be very good, you can certainly see people be very concerned about that. And we certainly heard that as well.
You led a working group to develop a critical care triage protocol for Ontario. I understand it hasn't been released yet, but can you talk a little bit more about the importance of having a protocol in place and why you took those early steps to try to get the right group of people in the room to talk about that?
Yeah, so I mean, really, our efforts were driven by an understanding that in Canada, as in many parts of the world, our ICU resources normally operate at or near their capacity. And so when we have the ability to handle mild and even moderate surges in demand. But when you have major surges like the kinds of things that were seen in China and in Italy in the early days, that would have exceeded our capacity. And Italy is a great model for Canada because they have almost exactly the same number of ICU beds per capita that we do. Now, Ontario actually had a plan from 2006 in the wake of SARS. Ontario was quite heavily affected by SARS. And we really hadn't updated it, though, in 15 years. And so really what we did was we took the information, we took the previous plan. There have been a number of engagement efforts over the years of population, working groups, and stakeholder groups to talk about some of the values. And we took all that, put it together, and tried to develop a more updated version of the protocol. Now, it's really important to understand what is the logic and the principle of a protocol, right? So the need to triage people, and it's important to remember this, the need to triage is created by the surge in demand. The need to triage is not created by the triage protocol, right? So whether or not you make a triage protocol, you will still end up triaging if the surge goes above a certain amount. The idea behind the protocol is that you're trying to develop a rational approach to handling it, a clear plan where rules will be developed that will hopefully maximize survival, minimize mortality, minimize the number of people who will be denied critical care, and obviously try to improve outcomes for everybody. It's like, I got a little tired of telling people this, but we're the fire department. We're not the fire, okay? Now, ultimately, having a plan is better than no plan. And so our principles that we tried to base this on was, first of all, medical utility. So give resources preferentially to those with the greatest chance of survival and recovery. Proportionality, right? So you don't want to turn off life support and turn a whole bunch of people at the door only to find out that the surge wasn't as big as you needed. And there's a lot of people that you might have been able to offer these resources to save them. So you only dial up your triage to the degree needed. And then finally, fairness, right? So you're going to get people coming in with all kinds of conditions, not just COVID, but cancer, trauma, heart attack, and people with pneumonia and advanced illnesses. You need to be able to compare them all against the similar standard, at least, and be able to sort of compare apples to apples. You don't want people with certain conditions to be disadvantaged, even if they may have the same mortality risk as somebody with another condition entirely, right? So you want to be consistent. It's important also to remember that the ethics of triage are a little different than non-beneficial treatment, right? So these are people, if you're triaging, right, people still may refuse critical care. They may not want critical care being offered, and that's fine if they do. But there are some people who may benefit from it and may want it, but won't get it anyway. And it's about maximizing population survival. You're no longer looking at maximizing individual survival and reducing individual morbidity and mortality. One of the struggles, and there are many struggles in developing a triage protocol, I can tell you, if you want to make a lot of enemies really quickly, sit down and write a triage protocol. But the big issues that came up for us were around prioritization of people based on age, and prioritization based on sort of what we call social worth. So somebody from a healthcare profession or somebody who might be able to contribute to the triage response. Many jurisdictions decided that a younger person would be prioritized over an older person due to life course and what they call fair innings. And then they also said that if somebody was a healthcare worker, either because they were at greater risk of getting COVID because of their profession, and they could help the response if they recover, should be prioritized. In our case, we didn't really find either of those arguments really held, and due to sort of human rights and charter rights issues in Canada, we didn't actually put either of those in. Ours are strictly clinically based criteria without any preference on those bases. Now, remembering obviously at the end of that people may be very concerned about what a triage protocol does, right? That even if you try to make it clinical, there's inherent biases baked into the system. And that's a true statement, right? Illness and mortality is not randomly distributed in society. Lower socioeconomic status, vulnerable populations, people who are dependent on others are more likely to have comorbidities that increase their mortality, right? And so even if you have a perfectly rational triage protocol and you apply it flawlessly with no bias whatsoever, it will disproportionately affect the vulnerable. And unfortunately, there isn't any rational, clear way to get rid of that entirely. What you're trying to do, and what we tried to do in our protocol, was just to say, look, we're going to try to minimize the effect of this by proportionality, by only triaging as much as we have to, and then trying to keep as many rational and clear criteria in there that are clinically focused so that there is as little room as possible for inherent biases to creep in. And that was our approach.
I think you allude to something that really troubles me sometimes about this issue of triage, and that is that on one hand, while I see this goal of maximizing the utility of the system and saving the greatest number of lives is a worthy goal, this issue of systemic bias and vulnerability within the health system is one that's really hard to manage. And so I do see these arguments in favor of saying, well, maybe the fairest method is a lottery system, or one that is based on equity rather than maximizing the benefits as you've proposed. And I know it's a very kind of medical view, and it's shared by many to adopt the mechanism that you've adopted, but this issue of continual systematic vulnerability that's baked into the system is a troubling one.
It's hard, like I can tell you, even looking purely at clinical criteria, it's extremely challenging to set those bars and try to be consistent across illnesses. I think anyone would want to try to create a system to be as equitable as possible and as fair as possible to incorporate some of the issues that you're talking about. But I can give you a numerical risk for a lot of different conditions. But then how do I in the same sort of quantitative way factor in some of those other issues, right? So somebody who has an advanced cancer and somebody who has advanced liver disease, and they both have the same mortality, and one of them was a smoker and the other had a history of alcoholism. Okay, so those are factors. But one of them came from a poorer background, or had abusive history in the family, or history of sexual or physical abuse that contributed to their substance abuse, right? One of them lived in an area with good access to medical care. One of them lived in an area of poor access to medical care. One of them was genetically predisposed to addiction. One of them was not. It goes on and on and on. And how I wish I knew a way to factor those issues into a triage protocol. I would. The problem is ultimately that you just can't. It's hard enough to do it with the clinical criteria. And so as we hash this around in our group, our feeling was that the best way to try to do this was really to acknowledge it, to try to mitigate it as much as possible through proportionality. The other thing we're doing is we are setting up a surveillance and data collection system, if it does get used, to rapidly collect as much data as possible about how the triage protocol is being used, take that data, feed it back to the decision makers, and decide, do we need to make on-the-fly modifications in this plan to try to make it more equitable? Are there criteria that seem to be disproportionately used? Are there issues with how it's being interpreted? And using population data to look at whatever equity angles we can. Are there groups that seem to be disproportionately affected? Can we do something about that? And again, until we have data, our hands are somewhat tied.
Yeah, it's great to see that evidence-based approach, I think, because it does inform the decision-making. And I think, though, more fundamentally, if we don't have transparency about what these policies are, so for example, in Australia, we don't have these policies in place in every state, or if some exist, they're at a hospital level. And it's really then hard to have these public discussions and debate, and discussions that involve more than just bioethicists or the medical community, but involve a broad cross-section of the community. And we can't have those debates unless protocols are publicized. So I don't want to push you on that, because I know in Ontario, the decision makers at a higher level have some control of that, but it's certainly something from a legal perspective that is troubling to me as well.
Yeah, I mean, you're absolutely right. And I think, if there's anything that engages human rights and legal concerns more than a triage protocol, the list is short. But we certainly have had a number of a lot of legal input. The people who worked on this had a lot of background in legal issues related to sort of health law, and certainly the ministry lawyers were involved. An early version of this was released publicly. We did get a lot of feedback based on it. We have a revision ready to go. We're just waiting to get the last bits of input and stakeholder input from different groups that help us sharpen the language to try to make sure that whatever accommodations can be made to people with disabilities, vulnerable populations, protections. None of us who are involved in making this protocol want this thing abused. None of us want this used to disadvantage people in some way that is anything other than a clinical judgment. And again, remembering that triage decisions are really awful. You have to say no to people. I've never had to do this before in my entire career. Very few people have. And none of us want to be in that situation. So that's kind of what our approach was.
Yeah, and it, I guess, points to as well the importance of these public health measures that have been taken to flatten the curve and to prevent these surges from happening. So obviously, some of those are out of our control, but it's great to see that we're having an effect. what do you think some of the biggest challenges are, biggest learnings for end-of-life care in terms of what COVID's taught us? Has it taught us anything about good end-of-life care, or what problems has it exposed?
I'm afraid that there aren't too many things in the win column when it comes to COVID so far. I would say the only wins from COVID so far have been public health wins, and our efforts have been very successful in many parts of the world at flattening the curve. So Australia and New Zealand being great examples. Canada has done a decent job of flattening the curve of community transmission. Long-term care became a totally different story, which I'll talk about. But yeah, those are probably the only wins I would highlight.
Can I put you to that? Is it a win that somehow now death and dying have become more salient for people, and that potentially is because COVID cuts across age groups in ways that other diseases or illnesses haven't, or maybe haven't as visibly? So again, this is an anecdotal perspective, but it does seem to bring the issue of death and dying more to the fore, and perhaps has promoted more conversations about end of life in people. I might be being overly optimistic.
I mean, I guess you could call that a win. I would be more inclined to call it a win if that was something we had done deliberately, as opposed to just an accidental byproduct of a complete catastrophe that's killed, an uncountable number of people. It's really been, I think it has been a situation where, yes, anything that raises awareness of end-of-life issues in the public is good in that very narrow sense. But I think, you, and I know you agree with this, that the cost we paid for that public awareness campaign is one that I think we all would gladly have back. I think one of the other key things we've learned throughout this is that, and we knew this, but this brings it home, right? Is that people get good end-of-life care not by accident, but by deliberate effort, right? So although mortality rates have risen and we've had a lot of these excess deaths in many parts of the world, actually they haven't necessarily been good deaths, because what we've actually seen, certainly in Ottawa and many other parts of the world, is that palliative care units are actually emptying. So there are a number of empty beds in palliative care units. Consult rates have gone down because the normal referral sources have dried up, right? So most of the patients who come to palliative care settings come from hospitals, come from cancer centers, come from specialized areas, which are now being asked to kind of shut down their services during the COVID pandemic. And so a lot of people are kind of sitting at home suffering in silence and dying without the support that they might have been able to access had they been able to access the system as a whole. So palliative care tracks with the privileged. Palliative care tracks with people who use healthcare for other reasons as well. And so as COVID has disrupted so many aspects of our end-of-life care and acute care system, so have people they've been dying, but they haven't been getting to us. The areas where palliative care is weaker, like long-term care, for example, are the areas where COVID has struck the hardest. And so certainly in Canada, it's about 86% of all deaths were nursing home related deaths in Canada, which is an astounding proportion. And we had very little presence in nursing homes before. I can certainly tell you, since I've had to go into a lot of nursing homes in the Ottawa area, we've gone in a part of a team. We've actually gone into now a dozen nursing homes. We've seen over 1,000 patients and about 350 patients with COVID, and provided dozens and dozens of people with, acute palliative care, acute symptomatic management as they get near to the end of their life, just to make sure that they're comfortable and well supported. And that's been a real challenge. I think we've, for sure, our big failure, and long-term care was a very fragile sector in Canada to begin with, and COVID exposed every weakness in our long-term care system, and we're really struggling still to sort of fix those issues, and I think we're going to struggle for some time to come. But coming out of this, there will be, I promise you, a much stronger and more robust plan for caring, and particularly end-of-life caring for people in long-term care settings. I guess the other things you could think about, right, would be that how much we rely on staffing and in-person visits and family involvement, right? So as much as people kind of pushed for virtual care or telemedicine, Actually, I found that COVID has really exposed a lot of limitations of virtual care and telemedicine. Teleconferencing and telemedicine still heavily depend on a capable person being at the bedside, somebody with time and skill to actually implement plans. And of course, we just didn't have that. So yeah, I would say those are probably the big things that stand out.
And that capable person, I suppose, is not just the healthcare provider, but it's also the person's loved one or carer that really must be an essential part of their end of life care.
There's no question that long-term care all around the world, and certainly in Canada, depended heavily on these unpaid informal caregivers, family members, friends, volunteers, to come in and feed people, to change them, to interact with them, socialize with them, and then take all that away. You see the consequences. It was not pretty.
I hope some of these inquiries and investigations now will lead to some positive change, but there's certainly lots of work to be done on that front.
Yeah, I mean, the sad part will be, I think, and I don't like to predict the future. It's much more fun to predict the past. But I can tell you that probably everything in these reports will be things that we've read before. Nothing in these reports probably will come as a surprise to us. And that's sad.
And yeah, and I suppose shouldn't surprise anyone, is still confronting, but points to the fact that now is the time to act. I'm mindful of your time here, James, so I'll just wrap up with a couple of questions that we're asking everyone that's participating in our Coffee with a Colleague series. The first is about collaboration. So I think we both know that medical professionals and lawyers sometimes butt heads. We don't always see eye to eye.
I've never seen that, not even once.
And there can be some disciplinary struggles. Certainly in our research, I feel like we do spend time trying to convince healthcare professionals about the benefits of knowing the law and learning the law and how that can benefit both them and patients and families. But I do think that when we collaborate and when the disciplines come together, when it works well, it works well. So what thoughts do you have about collaboration and what makes a good collaborator, especially one across disciplines?
Yeah, I would, it's interesting, right? I think fundamentally, the very best collaborations are always going to be based on respect and collegiality, right? So that's true whether you're crossing disciplines or not. But the bottom line is you need to be working with people where you can speak openly and disagree with them without fear of causing offense or worried that you're going to disrupt your collaboration, right? The last thing you want is a team full of people that just nod their head and agree with whatever you say, right? I mean, that's not helpful. You don't grow, you don't build new ideas, and you don't refine your ideas. When it comes to almost anything to do with end of life, whether it's non-beneficial treatment, triage, medical assistance in dying, or what you call VAD in Australia, all of these are very, at times, controversial topics. People have strong opinions, and often based not on sort of because they read a book and developed a very strong opinion based on a book or a paper. You develop strong opinions based on personal experiences, right? So these are lived experiences and deeply held values that people have. So they are roots. They are at the root of who you are. So talking about them can be very emotional, and it can really engage parts of the brain that aren't given to deliberation and thought. So if you're working in a group with people who all have the same opinions, that's fine. And then you'll see sometimes work where it's like a pro-con, where you'll see somebody present one opinion, somebody present the contrary opinion, and that's fun to read too. The very best work, though, is always when you form a group of people who actually disagree with each other on aspects of the subject, respectfully challenge each other, and then develop a dialogue that leads to each side getting a deeper understanding of their own position as well as the other person's, right? So as you throw out your arguments, they push back on your arguments and say, well, actually, I don't think you're right about that. And then you have to think, and you're like, well, okay, well, maybe what I meant was this. And then you have to drill down, and you drill down, and you drill down. And eventually you hit bedrock. And you'll learn so much about yourself, as well as learning about what the other person thinks. And of course, the process itself is a wonderful genesis of ideas and thoughts. And you learn a lot about yourself, and then you also identify the common ground. right? Because on every subject, although it may seem like you have diametrically opposed opinions in the room, as you start to explore things, you'll find out that you probably agree on 90+% of the subject. And it's just very specific issues that you disagree on. Identifying that really leads to an advancement of dialogue, right? So, you need the right people, you need the right settings to do this. You need to stay away from sort of tribalism and polarization.
And I think setting is key, and that's one, that we've struggled with at the moment with people not being able to travel. So sometimes getting in the same room is really key. I've certainly had experiences like you've described where people are testing each other's view, but it also requires a certain degree of openness and willingness to look outside of your discipline or outside of your comfort zone or take some risk. It's interesting that you've got sort of similar thoughts on that. The next question I had was, can you give any advice to early career researchers or those who want to do more research in the medical legal space or get involved in policy development, law, or ethics?
Good luck. No, I mean, I mean, good luck. And I mean, it's tough, right? Like, these are not questions with easy answers. And if this was easy to solve, we would have solved it by now. Nobody's really got great answers, and we're getting better. We're understanding better some of the issues that drive these problems, but I think we're still a long way from having any sort of very good solution to them. It's a rich area. A lot of work has been done, so you have to do a lot of background reading and research in order to bring yourself up to speed. Try to read a bit before you jump into a project, because you don't want to duplicate what other people have done. There's so many surveys about perceptions and, lots of qualitative stuff around futility and that sort of thing. And I don't mean to denigrate any of that stuff. It's good to have it, but now it's there. Is there a great value in adding another paper that's done the same thing, or, doing it in a slight, 5 feet to the left? And so, like, is this really of great value? And that's a bit hard, right? So try to join a group, find other researchers and like-minded people around you, and then you can bounce ideas off each other, and others may be aware of initiatives that are ongoing. The other thing you can do is reach out locally to committees or groups, right? So whether it's your hospital or something in your region, or even in your state or province or in your country, there are a lot of working groups and committees that work on this issue. Make important people aware that you're interested in and would be willing to work on stuff, because you'll be surprised that, it's remarkably easy sometimes to get onto working groups and make your work count and be part of the cutting edge of moving this issue forward, right? So that would probably be the main parts of my advice.
That's great advice, James. I think I've seen that myself with volunteering for certain groups, a clinical reference group I'm on at one of the hospitals here. And I know I've seen you do that in your career with just starting up groups and getting the right people in the room to talk about these difficult issues. So the final question I had, just to wrap up, was, what's the next big risk you want to take with your research, or the next big problem you want to tackle?
Yeah, I think the answer would have been different 3 months ago than it is now. I think there's obviously a lot of still interesting things to ask about triaging related to COVID and related to any pandemic in the future. And I think given how much work we've done over the past few months, probably be good to kind of see that through to the end. But coming back to the more enduring issue that we started about, which was non-beneficial treatment or futility, I still think that's probably the bigger issue long-term for us, because this pandemic will end one way or another. I'm very much interested in trying to develop newer mechanisms and newer means of resolving non-beneficial treatment, particularly in Ontario, where I work, because there's a lot of there's legislation, a lot of court cases, policies. It's been a fairly active area, and I feel like we're something of a leader in this field. I feel like if we could, what's been sort of this kind of swinging pendulum between patient autonomy and physician autonomy and patient autonomy and physician autonomy. And I'd really like to kind of break that if we could and actually move forward. It's not really about patient autonomy or physician autonomy. It certainly shouldn't be. And I feel like, given our experiences and given the way that things are going, I feel like there is an appetite now to really sit down and come up with a mechanism that we as a society can work with. that is actually going to be based on something like a standard of care for when we use critical care, when we use CPR, and when we don't. And then making sure that there's an effective mechanism to ensure that the standard is delivered. Transparent, timely, responsive ways of appealing decisions or double checking, even if you don't want to make it controversial or you don't want to be sort of have a conflict, but you're just genuinely unsure of what you should do. You're sort of in a borderline case. Just be open about that. I don't know. I'm going to ask for a second opinion, or we're going to try it and see how it goes. I think there's tremendous people. The way things are in Ontario right now, I think things have improved a little bit with some more clarity in recent court cases and policy revisions, but there is still potential, and I think this potential exists elsewhere in the world as well, for people to misuse the current standards and mechanisms in what would be a cynical way. I think that makes matters worse. I think it undermines trust in the system between everybody. I think we can do a lot better than that. So that if I had to pick one topic that I really want to work on, a risk I want to take, it's to try to wrestle with that beast.
Thanks for that, James. I think that's a good spot to end. So thanks so much for your time. It's great to hear some of those challenges you've highlighted in Canada and in Ontario. We share some of those challenges here in Australia. And so I look forward to working with you more and hopefully doing some more collaborations in the future.
Well, likewise, I think the next few years will be a lot of fun.
Thanks, James.